Mr. Chairman, Mr. Chairman of the course, conversion from off to on pump in cabbage, can it be avoided? The Mark 14 torpedo was the United States Navy standard submarine-launched torpedo in the Second World War. In the first part of the Second World War, 70% of these torpedoes misfired. They had four major issues. I like to address this issue here in Russia, talking about an American torpedo, but four major deficiencies. It tended to run about 3 meters deeper than set. It ran in circles. The magnetic exploder caused premature firing, and the contact exploder failed to fire often. Basically, it was three major problems. It was a problem of conceptual design. The Mark 6 exploder malfunctioned, and there was an unrealistic exploder sensitivity setting. So the setting at which contact level it would explode was totally unrealistic. There was a failure in outcome analysis. They had a feeble testing program. They only tested it on one particular area in the world with very specific magnetic properties. In fact, the critical funding to test the outcome, to do the outcome analysis correctly, was cut by the US Congress. In fact, they went to war with this torpedo, and they never even tested it on one single ship. And then there was a failure in training and maintenance. They had a beautiful service manual written, but it had been locked up for security reasons. So, let's look at the conversion rates in OPCAB. What has this to do with it? Well, you will see that it's exactly the same issues. Well, if you look at the DOORS trial, the Ruby trial, and 3 trials, I just take here through 3 trials. First of all, we have no idea what kind of population is actually undergoing off-pump surgery. So we can only guess. And if we take the world average, we would say around 30% of the patients. So as you can see in this coronary trial, they had no standardized concept, no mandatory shunting, no pulmonary artery monitoring, no idea about the anticoagulation levels, no idea about the avoidance of inotropes, and in fact they had absolutely no training process, and they had 7.9% conversion rate. In the DOORS trial, and I know most of the surgeons had been to our institute to come and look, but that doesn't mean that they have actually followed that. So they seem to have a standardized concept. I don't know if it was applied, but at least they had it written out. They had mandatory shunting, but again, we don't know if it was done. They had pulmonary artery monitoring. They had an ACT. They did not avoid inotropia, and we had no idea about their extensive training except for a tourist trip to Leuven. Their conversion rate was 13.6%. In the Ruby trial, the same. Well, the Ruby trial is a similar issue. So if we look in Leuven, in the first 144 patients that we did without really having a concept, we had no concept. We did shunt from the beginning, but basically we had no standardized pulmonary artery monitoring, no idea about anticoagulation, inotropia, and we didn't have an actual training process. So here we had 2% conversion rate. But in the 6,000 patients, once we had an actual standardized concept, we were able to bring this down in total over this whole period to 0.2%. In fact, the first issue when you talk about conversion to another approach is in what percent of the patients are you actually applying this process. And as I stated before, we're applying off-pump, in fact, in 98 to 100% of our patients for many, many years. Since 14 years, there has not been a perfusionist in our operating theater, and there is no machine in the operating theater. We have very strict rules on the standby of the machine. In fact, there's no standby when the patients are stable, but at night when there's emergency surgery, then a perfusion setup and a perfusionist is brought to the operating theater. And again, the decision about the conversion, the appropriate action, is all written down in concept. The consequence of this is then here you see the first 4,500, we're now way beyond 6,000 consecutive patients. operated on pump, off pump, is just this early conversion rate, but out of then conversion has been gradually going down to less than 1 out of 1,500, and in fact the last 3,000 patients we did not have a single conversion. Please understand that these procedures are not done by me. I may be in the room, I may be first or second assistant. They're done by young surgeons, 27, 28, 29 years old. What are the consequences of conversion? Well, the consequences are conversion. You see here 5 different data sets. You see here the number of patients in this data set, and you see the number of patients. To be able to have statistical power, you must have enough conversions. So with 13 patients, you can guess that we cannot create too much statistics. In fact, in our unit, there was no effect on mortality because there was not a single patient of these 13 that lost his life, so you cannot have an effect. And yes, these other 4 studies identify that conversion are an issue. In stroke, we didn't have, I think we had 1 patient with a stroke in that cohort. Clearly the others state no power, and the same thing here. But with the red signals, it's clear that conversion has an impact on mortality, has an impact of stroke, and certainly we identified an effect on positive enzymes. And by definition, it will have an effect on the cause tissue, as you can see in the doors in the Ruby trial, the economic section of the Ruby trial. So to avoid and to be able to reduce this conversion, we organize seminars in Leuven. We've organized 540 seminars with 1,140 doctors from 58 countries, of which are 100, and that's what Professor Bukarian asked me, 100 surgeons from Russia. In fact, we've done 46 seminars, and that's now not in our own institute, but at different places in 23 countries, of which 6 of them in Russia. We have to understand that you do not learn a procedure by coming to watch somebody. That's a live procedure. And I call that the folie bergère. The folie bergère is no educational pathway. In fact, I have the luck of spending my summer holidays, please be certain, with my wife in a resort in France, and the girls from the Lido take their holidays also there. So we know a lot of them, of these girls from the Lido. They dance in the Lido not because they have long legs, but because they are too tall, and but they have 20 years of ballet. So if you go to the Lido and the Folie Bergère, please go there to enjoy your evening, but do not think that you're going to learn to dance. They know how to dance because they have 20 years of ballet. Now, why does it fail? Why have so many units failed in OPCAB? Well, first of all, there is a science of learning. We think there's only a science of cardiac surgery. I'm not going to go into detail, but it's about taxonomies of learning objectives. There's theories of adult learning. There's dynamic theories of organizational knowledge. For certainly this aspect, dynamic theory of organizational knowledge creation, an essential part in the off-pump technique. So where does it start? Well, we have to know that a complex new procedure, and I'm not saying a difficult procedure, I'm just saying it's a different procedure. You need conceptual learning, and conceptual learning is the process of acquiring a better understanding of cause and effect relationships. Conceptual learning needs to know why a problem happens, and then you have the operational learning. So what is conceptual learning? At our unit, every single process is written down in detail. On the left side here, and it's not important what is there, this is a 3-second maneuver. This is a 3-second maneuver of placing a shunt. You can only learn that by first knowing these 30 lines by heart. That's the process. That's the conceptual learning process. And then you have the virtual learning process. We've realized that many of the guests that come to our place are missing some fundamental skills, and that's why we've now set up a series of simulation labs. In fact, I'm going back tonight because tomorrow morning at 8 o'clock I organize another simulation lab in Spa in Belgium. I had one on Tuesday in Maastricht. Residents in our unit, they train on simulation. They train anastomosis in horizontal planes in simulation because, in fact, our operating environment has moved from a from an airspace of around 2 meters to an airspace of 1 centimeter. 1 centimeter, 7 centimeters down on a moving target. You cannot do that with the traditional instruments. You cannot do that with the traditional, just by looking at somebody. It's something you learn in simulators. It's easy to learn, but you have to learn it. Just as the young kid who lands his plane on an aircraft carrier. This is a guy from Uzbekistan who was with us for 3 months. He did 800 anastomosis on the simulator, and he moved right on to an off-pump LED, and it was just a perfect anastomosis. One of the issues that people have is they cannot navigate in a reduced airspace. They cannot navigate in small spaces. Well, first of all, it starts with the needles they use. In the United States, 80% of the anastomosis of coronary surgery are done with a 7-0 needle. The same thing in Russia. The numbers are that they use a 7-0 needle. Well, a 7-0 needle is a 9.3 millimeter needle. It makes a 250 micron hole, but it then demands a minimum space to make the circle of 8 millimeter. We've been using an 8-0 needle, which is only 6.5, so our minimum airspace is 6 millimeter. And with a certain number of skills, you can rotate that needle in a lot less than 6 millimeters. In addition, we have created a MOOC. A MOOC is a massive open online course. A MOOC is a course where, in fact, once you have gone through this simulation training, you are then invited to come into the cloud. We have this cloud project where we train 1,200 surgeons at this moment in the cloud from home on the simulators. We also have built into our system, and that's the reasons, so one of the reasons why we have low conversion rates is because we really follow the science of learning. We have conceptual learning, but we also have, and we have virtual learning, as we have told you. We then have operational learning. Let me try to understand, to give to you the message what is operational learning. We have huge databases, so it's all driven by data. And in fact, when you move from one technique to the other, you need extensive data of the old technique, and then you move to the new technique and you collect extensive data. If a plant, for example, Volkswagen or Porsche, is going to have a new type of metal to create its car, it has thousands of records of the previous metal deliveries or steel deliveries, and then they are comparing this. So it's an issue of data. If you don't have the data, you cannot control yourself, and you cannot do operational learning. This gives you an idea of our first experience, our first 3,000 patients. You see a running average of the predicted risk. And here you see how gradually in the running observation of the observed risk, how that risk dramatically went down through the operational learning process. That has been also in the literature mentioned repeatedly, that if you do this under the correct format, you have very rapid learning processes. So conversion in OPCAB is a human failure. And when I say the 12 patients that were converted, it's a human failure. And I'm pointing at the right person. I'm pointing at the doctors who do the procedure. It is because your concept is incorrect, because you think that you can run away without observing ischemia, because you think that you can run away without avoiding ischemia. It is an issue about some skills, and skills is not something you get with birth. It's something you can train for in simulation, and it's an issue of operational learning. Often maybe due to an absence of skills and instruments. You need some specific instruments, but that's not really the secret. But I'm sometimes confronted with surgeons who tell me, well, in our hospital there's only one Castro-Viego needle holder. Well, that is an issue, of course. But in simulation we now provide instruments, and I provide a lot of instruments for free with less around €100 for a perfect needle holder and a perfect forceps. Because modern OPCAB surgery demands to be able to perform an anastomosis in 1 centimeter airspace, 7 centimeters down on a moving target. Any conversion rate above 1% should immediately be addressed, because it will annihilate all possible benefit of OPCABs. And that's so many of the studies involving on-pump versus off-pump have in fact had their results annihilated because of incredible conversion rates. Dramatic benefits of OPCAB become visible with conversion rates around 0.1%, so 1 promille. And I thank you for the privilege.
Thank you very much for an excellent presentation. The paper is open for discussion. Leo, please.
I don't know. I have a remark and I have a question. First, I don't know who is using 7.0 and 6.0. Nobody at Bacula, okay? We use either Vina or Atari. We use 8.0, okay? Mm-hmm. And I know even that in some places at federal centers, they use even 9. I cannot do that because I don't know what kind of glasses I have to use, but they use even 9. And that's very important. I agree totally that the needle should be very, very thin, and that's a key point. But my question is, how about, you were talking only about the technique, right?
Yes.
How about anesthesiological part in having good results? I mean, how much about, general experience of a surgeon when he feels that the hemodynamics is changing? How about the anesthesiologist? How this team, except this, making hundreds and thousands of sutures?
But that's, your point is very correct. It's what is called the conceptual learning process, is writing down. In our unit, every single step of anesthesia is written down. Mm-hmm. In fact, it starts as soon as the patient is intubated. We go through a whole process of not only of monitoring, but also of conditioning this patient. We are bringing this patient into a physiological environment. If the heart rate is too fast, if the heart rate is too slow, we bring the patient into physiology. And that's, so your point is absolutely correct. What I have seen with the Russian surgeons who have visited is that some of them, and please, it's nothing personal. It's something. It's an observation that our team has seen on the Russian teams. Is that first of all, Russian surgeons communicate very little with Russian anesthesiologists. The Russian surgeon wants to be the alpha male in the operating environment.
You can see that in any country, it depends.
Yes, well, it is not really true, because there are countries where that is not the case. There are countries, and I have experience with people from many countries. Mm-hmm. So in Russia is the alpha male, and of course in an operating theater with OPCAB, you're a partner. In fact, there are 3 partners. There's a scrub nurse, there is a surgeon, and there's the anesthesiologist, and you are a team. You have to interface. Mm-hmm. The biggest problem when I have visitors from Russia is to have them make silent so that they can hear the communications that are going on between the surgeon and the anesthesiologist and the scrub nurse. And that's the core of the essence. Now, this means that it's something you can only learn as a team. Let me explain. In the science of learning, there's something called tacit learning, and there's something, the more visible learning. The apparent learning is easy. I mean, you can just share a sheet of documents, and that is easy to transfer. The most difficult knowledge to transfer is what is called the tacit knowledge. From the Latin word tacitus, it's the silent knowledge. The silent knowledge is usually embedded in group behavior, and you can only learn that by coming as a group. And that's where some of the visitors fail. So can you learn OPCAB? Absolutely. Maybe not in 3 days, but you have to read the documents, you have to go through the process, and try to benefit what other people have developed.
I agree about protocols. That's very, very important. We've been for 19 years in joint cooperation with the United States, early years, and what they started at that time, my senior friends and teachers, they started with the protocols. And when they made the joint protocols, in fact, the results were same both sides. In fact, that's what I know. But the next question is, what is the difference between team performing, there's cooperation between surgeon, anesthesiologist, how it differs when it's off pump and on pump? Is there some specific difference?
Oh yes, it's absolutely different. In fact, we had people from communication department studying, and they have published that, the communication systems, and in fact the communication intensity in the operating theater, and they compared it with the intensity in the cockpit. And they discovered that in OPCAB there is a much higher intensity of communication within the team than within the cockpit of an airline.
Why shouldn't you say about that? That's very important for all those who are sitting here. Could you say a few words about that?
Yes. Well, it first you must have silence in the room. That's the first thing. The next thing is you must respect somebody else's opinion, which means that, as an example, I am a few weeks from the end of my career. There's an anesthesiologist that has been 14 years in my operating theater. Not a single time has he said, let's go on the pump. I mean, it doesn't even come in his ideas. But what has come in his ideas is that he says to me, let's just wait a second. Let's just give me time, give me 10, 15 minutes time to bring the patient back under the correct conditioning. And then you don't touch the patient. But again, our rules are very strict, maybe stricter than most surgeons can accept. Maybe they should accept, but that's our rules of the game. As I said this morning, not a single extra systole. I mean, we have 0 extra systole. We have never inotropia. I usually, a little bit teasing, I say that if the young anesthesiologist gives inotropia, then we have 2 deaths. The first is the patient, and I'll take care of the second death.
Does it mean that you cannot do surgery any place without your anesthesiologist? Can you make surgery at Baculeva, for example, without your anesthesiologist?
Absolutely, because it's an issue of protocol. It's done. The operations are done by very young anesthesiologists, and after one day, if they follow the protocol, you can be an old anesthesiologist and not follow the protocol. And if you're a young anesthesiologist and you follow the protocol, this is just absolutely perfect, absolutely, unconditionally. It's just a protocol issue.
Yeah, I see. So you can come, let's say, in Pavlodar, or I just want to realize, because when I go to do surgery, I take my anesthesiologist and intensive care. I mean, inside the country, right? Because you want to feel like you feel usually. But if I can rely on the protocol when I'm leaving for the other place, I'm not sure that I can be safe.
I've operated in quite a few places in Russia where, in fact, what happened then is the anesthesiologist had been in Leuven before and then followed the protocol. But it's just a matter of protocol, yes, and the training process.
Paul, you have shown us an extremely streamlined operation for off-pump cases.
Yes.
Sometimes you need a pump, occasionally. How can you maintain a pump team with this caseload?
Well, you cannot maintain a pump team if you do only coronary surgery.
So that's a problem then?
No, it's not a problem, because in our unit we still have around 900 patients on the pump. Or 800 patients using the pump. We have 7 perfusionists in our house. But as I stated, when there is an emergency procedure at night or in the weekend, then a perfusionist comes into the room.